Bismillahirrahmanirrahim. Now we are going to start with the right ventricular myocardial infarction. So in the right ventricular myocardial infarction, the leads which are important are lead 2, 3 and AVF. So in the picture you can see that we have ST elevation in the lead 2, in the lead 3 and in the lead AVF because they correspond to the inferior surface of the heart and the area of the heart that is being supplied by the right coronary artery. Now 50% of the right ventricular MI are associated with the inferior wall, 2, 3 and AVF ST elevation, myocardial infarction. There may also be reciprocal ST depression in the lead 1 and AVL in acute inferior wall MI. Right ventricular MI leads to impaired right ventricular filling and creates high sensitivity to intravascular volume depletion. Thus, administration of any drug that decreases the preload should be avoided because they cause abrupt decrease in right ventricular preload and lead to profound hypotension. Such drugs are nitrate, they can cause venodilation, opiates which cause venodilation, so opiates can also cause venodilation, and diuretics, they cause volume depletion. So these drugs are to be avoided in the right-sided heart failure. Optimization of right ventricular preload. Patients who fulfill a certain criteria should be given IV fluids to increase the right ventricular load because of that Starling mechanism that when you stretch the wall, the contractility increases and stuff like that. The criteria is that suspected right ventricular MI with the following features. So in these people, we can give intraventricular fluids. Like the people who have hypotension, low or normal jugular venous pressure that is less than 3 centimeter of water above the sternal angle at 30 to 45 degree recumbency, no pulmonary congestion and no evidence of right-sided heart failure. Only there is right-sided infarction, yes, that is going on, but it has not gone all the way to frank infarction. If it has not gone all the way to frank failure. If the hypotension, so the difference between the infarction and failure is that suppose this is the heart and this is a particular portion which has become ischemic, so that is like infarcted area. And if the whole heart stops contracting, so that is either it stops contracting or either it stops contracting in systolic heart failure, or maybe it is so thickened or so stiff that it cannot fill properly, that is in the diastolic failure. So that is a failure. Failure is a different thing than infarction. Infarction can lead to failure. So if hypotension persists despite the adequate fluid restriction, inotropic agents can be considered. Management is dual antiplatelet therapy, anticoagulation, and percutaneous intervention. Inferior wall MI. So inferior wall MI, it may be caused by the right coronary artery blockage or left circumflex blockage. The right coronary artery blockage is more common. It is most commonly associated with the sinus bradycardia due to increased vagal tone in the first 24 hours after the infarction and decreased right coronary artery blood supply to the SA node. On ECG, it shows ST elevation in the leads 2, 3 and AVF, and there may also be leads 1 and AVL ST depression, that will be reciprocal depression. The right coronary artery blockage. This can lead to inferior wall MI, morbid type 2 AV block, 2 P waves for every QRS complex. It is not necessary for 2 P waves to be there for every QRS complex, but basically the point is that in morbid type 2 the PR interval is fixed and there is the beats are skipped in between. The right coronary artery supplies AV node through the AV nodal artery. The right ventricular MI versus pulmonary embolism. So in the right ventricular MI and pulmonary embolism are difficult to differentiate. The right ventricular MI is less likely to cause dyspnea or syncope as in pulmonary embolism and more likely to cause bradycardia or arrhythmia. So the right ventricular MI is less likely to cause dyspnea or syncope and more likely to cause bradycardia or arrhythmia, while the pulmonary embolism is more likely to cause dyspnea or syncope. Okay, so estimation of central venous pressure, the CVP is equal to jugular venous pressure plus depth of right atrium, which is 5 centimeter. So like from the sternal notch, the depth of right atrium is 5 centimeter and more than 3 centimeter above the sternal notch if we have jugular venous pulsation. So it is kind of normal because I guess 8 centimeter is normal. Okay, so the jugular venous pressure from 1 to 3 centimeter. This is sternal angle. So if we erect a scale over here and if we see the pulsation at 3 centimeters, so this is normal, and depth of the right atrium is 5 centimeters, so total of 5 to 8 centimeters 6 to 8 centimeter of water is normal. And if elevated like more than 8 centimeter, that is the point of 8 centimeter, and if it is more than that, so it is elevated central venous pressure. Jugular venous pressure in different cardiac pathologies. So in atrial fibrillation, the A wave is not present because the A wave was there because of the atrial contraction. And if we are not expecting A wave, so we have a flat A wave, and this the jugular venous pressure, instead of looking like this, it is looking like this. So in ventricular diastole, there is no A wave, but the rest C, X, V, and Y waves are normal. We have talked about that in detail when we were talking the we've discussed this, I guess, in one or two sessions back. You may see that from over, but okay, to revise for the revision purposes, you must know that the A wave corresponds to the atrial systole. The C wave means, like, suppose this is the heart. Okay, my PDF is not cooperating. Yeah, this is the heart, and these are the atrial ventricles. So when during ventricular systole, when the ventricles start contracting, the tricuspid valve is pushed upwards, and the tricuspid valve is pushed upwards into the atria. So that slight tricuspid movement into the atria creates this C wave. Then so we are this waveform, that is jugular venous waveform, it is basically corresponding to the atrial pressure changes, right? So the A wave was when the atria contract, then C wave is when the ventricles contract and tricuspid is pushed into the atria. Then this X descent is during the atrial diastole, when the atrial wall is relaxing and the blood from the venous system is entering the atrium, right? That is giving us the X descent. And then slowly the blood starts entering, and the pressure in the atria starts rising up till a maximum of V. So the V is the point just before the tricuspid valve opens. The maximum level of blood that is accumulated in the atrium before the tricuspid opens creates a V wave. Then the tricuspid valve opens and the blood moves passively into the ventricles. That is going to give us the Y wave, Y descent, and that is happening due to the ventricular diastole. And then again the atrial wall starts contracting, and the atrial contraction gives us the A wave, which will push the remaining 20% of the blood into the ventricle. They have given us that as well. So A means atrial contraction, the C wave corresponds with the ventricular contraction, X means atrial relaxation, V is maximal atrial filling, and Y means atrial emptying. In cardiac tamponade, the waveform looks something like this. It is pretty much similar, but the Y descent is gone. There is no Y descent in the atrial tamponade. The Y descent was, why was there a Y descent? Because of the when the tricuspid valve opens, the pressure in the atrium falls because the blood has started entering the ventricle. But since in cardiac tamponade, suppose this is the heart and this is the pericardial fluid and pericardial space that is filled with the fluid, so it is exerting pressure on the heart from all the sides, especially on the right heart and the right atrium. So the pressure in cardiac tamponade, we have a concept of pressure equalization. So the pressure in the right atrium does not change even when it is emptying. So the Y descent is gone. That is a very characteristic finding in the cardiac tamponade. Again, we have this. The rest of the wave looks pretty much similar. Then we have tricuspid regurgitation. In tricuspid regurgitation, you can see that the A wave is there, but instead of X descent, because in ventricular systole the atria is contracting. So when suppose there is tricuspid regurgitation, the like this. So the tricuspid valve is not patent, and the time when the atria was supposed to relax and fill with blood, the ventricular systole is happening, and ventricular blood also starts moving into that. So there is no X descent. The V wave is at a higher pressure point, and the Y descent is present. So in cardiac tamponade, there is no Y descent, and in tricuspid regurgitation, there is no X descent. Got it. Then we have this thing, that is mechanical complications of acute myocardial infarction. This is a table from first aid. You can see it over there as well, but let's start it. The common complications which are happening after acute myocardial infarction. The first complication is reinfarction, that can happen hours to days. Within hours to 2 days, the reinfarction can happen. Then there is a chance of ventricular septal rupture, which can happen within hours to 1 week. The free wall rupture can happen within hours to 2 weeks, and post-infarct angina, there is another thing, that is chorda tendineae rupture, that can also happen within hours to 1 week. Then comes post-infarction angina, which can happen from hours to month. And then we have the papillary muscle rupture, which is 2 days to 1 week, right? Then pericarditis 1 day to 3 months. Now it is like written like that, but the post-infarct pericarditis happens within 1 to 3 days. Then there is a window in which pericarditis is not present, and then comes the Dressler syndrome, which is also a form of pericarditis, but it is an autoimmune pericarditis, and it happens weeks to months later. And then left ventricular aneurysm 5 days to 3 months. Basically, it is not happening after 5 days. In most situations, it develops after at least 2 weeks or more duration, because the aneurysm will form when there is no risk of rupture, when the scar tissue has formed. So that scar tissue, the formation of scar is completed within 2 weeks, and after that, we have a chance of development of aneurysm. Development of hemodynamic compromise in the first few days following MI raises suspicion for the mechanical complications of MI. Like suppose there is some papillary rupture or maybe some free wall rupture or something. A delay in the coronary reperfusion more than 24 hours from the symptom onset correlates with the extensive myocardial death and increased risk of mechanical complications. Three major mechanical complications are papillary muscle rupture, left ventricular free wall rupture, and interventricular septum rupture. The papillary muscle rupture. The presentation is sudden onset pulmonary edema because the papillary muscle, the posterior medial papillary muscle of the left side ruptures, and that can cause mitral regurgitation, and that mitral regurgitation will result in pulmonary edema, and that will be of sudden onset. Mid to late systolic murmur consistent with mitral regurgitation, best heard at the apex. Possible cardiogenic shock. In up to 50% cases, patients may have a soft or no audible murmur, that is silent mitral regurgitation. Then interventricular septal rupture, the presentation is obviously hypotension, that ventricular wall has ruptured and blood has started pouring into the pericardial space. There will be heart failure and a pan-systolic murmur will be heard. I'm sorry, it's interventricular septal rupture. So that will create a VSD. Like suppose this is the heart and the rupture is here, so the left to right shunt is created. That will create a pan-systolic murmur. And there will be hypotension because blood, instead of moving into aorta, has a shunt pathway through which it is moving into the right atrium. So decreased amount of blood is reaching systemic circulation, that can result in hypotension. It is best heard at the left sternal border, accompanied by a thrill, and that will be a harsh murmur. Differentials include acute mitral regurgitation due to papillary muscle rupture. Mitral regurgitation systolic murmur is soft. There is no palpable thrill. Then these are the lead localization of the myocardial infarction. So interior MI is caused by the left anterior descending artery, and some or all leads from V1 to V6 will be included. Inferior MI, right coronary artery or left circumflex artery, ST elevation will be seen in 2, 3 and AVF. Posterior MI. Now the concept is like in the inferior MI or posterior MI, why are we considering left circumflex artery? Because there is a concept of predominance, and in some people the posterior descending artery is originating from the left circumflex artery. In others, it is most of the people it is originating from the right coronary artery. So in posterior MI there is ST depression in V1 to V3, ST elevation in lead 1 and AVL if the problem is in the left circumflex artery, and ST depression in lead 1 and AVL if the problem is in right coronary artery. Lateral MI, left circumflex artery and diagonal artery, ST elevation in the lead 1, AVL, V5 and V6, and ST depression in lead 2, 3 and AVF. This is reciprocal depression. So it is kind of a rule, like the prominent leads, like for the right side heart, 2, 3 AVF will have ST elevation, as you can see, and there will be reciprocal depression in 1 and AVL. Right, and here you can see that there is one in the left-sided leads we have ST elevation like 1 AVL, V5 and V6. So there is reciprocal depression in 2, 3 and AVF. Right ventricular MI occurs in half of the inferior MI. The arteries, right coronary artery and ST elevation in the lead V4 to V6 is happening. Okay. No, and you must remember that it is V4 to V6 are, right? These are not V4, V6 of the left side. It is when we apply the heart leads in an opposite direction, like instead of placing them on the left side, we place them on the right side. Then there is elevation in the V4 to V6R if we are suspecting a right ventricular MI. Okay. Mechanical complications of acute myocardial infarction. So the first complication is the first right ventricular failure. The time course is acute. The involved coronary artery is right coronary artery. The clinical findings we will be having include hypotension with clear lungs, because the problem is proximal to the lungs. If I draw heart over here like this, so these are the four chambers, and the lungs are connected to the right ventricle, right, through the pulmonary artery. If the problem is that the right ventricle has failed, it is not pumping the blood into the lungs. So the problem, since it is proximal to the lungs, so the lungs will be cleared, and there will be Kussmaul sign. What is Kussmaul sign? Normally, when we do inspiration, So on inspiration, the jugular veins are collapsed because the blood is, when we are expanding when we are inspiring, the thorax is expanding and more blood is entering the right heart, so the jugular should collapse. But if paradoxically during inspiration jugular veins start distending or they remain distended, that is Kussmaul sign, and that happens because the right heart is not pumping, right? So whatever blood is entering will not be pushed into the lungs, and that will become static, and the jugular veins will become distended even more. And echocardiogram findings will show hypokinetic right ventricle. Papillary muscle rupture, acute or within 3 to 5 days. The affected artery is right coronary artery. The manifestations that we find on the clinical examination are severe pulmonary edema and new holosystolic murmur. Severe mitral regurgitation with a flail leaflet will be echocardiographic finding. Interventricular septal rupture. The time course is acute within 3 to 5 days. The problem is with the left anterior descending artery, apical septal or right coronary artery, basal septal. So the clinical findings will show chest pain, new holosystolic murmur, biventricular failure and shock, left to right ventricular shunt, increase in oxygen level from right atrium to right ventricle. Then we have free wall rupture within 5 days to 2 weeks. The problem is in the left anterior descending artery. You see that the papillary muscle rupture is caused by the right coronary artery because the papillary muscle that is being ruptured is a posterior medial papillary muscle, and this papillary muscle is supplied by the branch of right coronary artery. I guess the posterior descending or maybe something, but that is being supplied by the right coronary artery somehow. Yes, the posterior descending artery to be specific, and that is when right coronary artery is occluded, so papillary muscle rupture can happen. While interventricular septal wall rupture, both of these situations are associated with the lead. So pre-wall rupture, it is associated with the chest pain, shock, distant heart sounds, and echocardiographic finding will show us pericardial effusion with tamponade. Left ventricular aneurysm, it happens up to several months after the MI. The obstructed artery is left anterior descending artery, and the clinical findings will include subacute heart failure and stable angina. And the next thing is the echocardiographic findings will include thin and dyskinetic myocardial wall. S3 gallop, it results from sudden cessation of blood flow into a dilated left ventricle during passive filling phase of the diastole. It is seen in dilated cardiomyopathy, heart failure, and severe mitral regurgitation. Absence of an S3 gallop excludes severe mitral regurgitation and aortic regurgitation. So we find an S3 gallop in these situations: dilated cardiomyopathy, heart failure, severe mitral, and aortic regurgitation. Now the catch is that the ventricle is already filled with blood. On top of that, more blood is entering, so that creates slushing sound, and that is S3, right? So S3 rhythm sounds like Kentucky, Kentucky. So like S1, S2, and immediately after S2 there is another sound, that is key. So Kentucky. So you can remember it like that, or I remember it the sketchy way, that is slushing in, slushing in, slushing in, because the recurrent symbol for S3 is a slushy, so they say that it is a slushing in sound. But if you want to remember like Kentucky, Kentucky, that's also good. Just keep one mnemonic, don't mess your brain with a lot of mnemonics, so that you don't remember what the mnemonic stands for. The second is S4 rhythm. So S4 rhythm sounds like Tennessee, Tennessee, which means that it is S4, S1, and S2. So Tennessee. So, and the sketchy mnemonic is, if you know they draw a stiff chair, so they say a stiff chair, like S4, S1, and S2. So just make a mnemonic out of that. But you must know the pathogenesis, that in the S4 heart sound is seen in situations where the ventricular wall has become thickened, and when the blood strikes with that stiff wall, so that creates a sound, right? That is S4, and that precedes S1 immediately, like that is just before S1, and the S3 heart sound comes just after S2, and that is because of an overfilled ventricle being filled with more blood. The gallop heart sounds, third heart sound, features are ventricular gallop sound after S2, heard during rapid filling of the ventricles in diastole and turbulent blood flow to the ventricles due to the increased volume. It is normally heard in children, young adults, and pregnant women, and it will be considered abnormal if it is present in the people aged more than 40, in people with heart failure, restrictive cardiomyopathy, and high output states. Fourth heart sound is S4. So atrial gallop sound, it comes before S1, It is heard immediately after the atrial contraction phase as the blood is forced into a stiff ventricle. So normally, it is normally present in healthy older adults, and it is considered an abnormal sound in younger adults and children, in the people with ventricular hypertrophy and the people with acute myocardial infarction. Viral dilated cardiomyopathy. Sudden onset of cardiac failure after a recent upper respiratory infection should raise suspicion for the viral and dilated cardiomyopathy. Most common viruses involved are Coxsackie B virus, which is most common, parvovirus B19, herpes simplex virus 6, influenza virus, HIV, adenovirus, and enterovirus. The pathophysiology is viral myocarditis can cause dilated cardiomyopathy via direct viral damage as a result of humoral or cellular immune response to persistent viral infections. The diagnosis of viral dilated cardiomyopathy is done with echocardiogram. As I mentioned in a previous session, that echocardiogram is a very important study as far as the CVS is concerned, and we'll find that in a lot of different conditions, dilated ventricles with diffuse hypokinesia will be seen on echocardiogram because it is a dilated cardiomyopathy and it is highly associated with the Coxsackie virus. Uh, but these other associations are also present. Treatment is supportive, management of congestive heart failure symptoms, because basically it is systolic kind of heart failure. The heart is not pumping, the heart is just dilated bag. And to support that, we give a lot of drugs we will see in the congestive heart failure, but it basically constitutes inotropic agents, beta. It is, no, that is for the ischemia. I think it was LMNOP. Yes, it was LMNOP. So if I'm not confusing myself, let's go back. That was Lasix, morphine, oxygen, nitrates, and the P was for something. But that was a few pages back. Let's go there. LMNOP. I think that was congestive heart failure. Yeah, they were saying that it was for decompensated heart failure, we give LMNOP, that is Lasix, morphine, nitrate, oxygen, and we change the position of the patient. Okay, so these are the management options that we administer to the patients who have dilated cardiomyopathy. Viral myocarditis, the clinical presentation is relatively young adult, that is age less than 60. Viral prodrome like fever, malaise, and myalgias. Heart failure like dyspnea, orthopnea, and edema. There will be chest pain and sudden cardiac death. Diagnosis is made on ECG, but that is non-specific. Echocardiogram will show four-chamber dilation. Cardiac MRI, late enhancement of the epicardium. Biopsy will show lymphocytic infiltration, viral DNA or RNA. Treatment: medication like diuretics, ACE inhibitors, and beta blockers. Temporary ventricular assist device if needed, and heart transplant if no recovery is seen. Then comes effect of nitrates. So we give nitrates in a lot of cardiac conditions to decrease the preload basically. So what are the effects basically? So the primary effect is vasodilation of veins, most importantly, then arterioles and then coronary arteries. Anti-ischemic effects of nitrates are due to the systemic vasodilation rather than the coronary vasodilation. Systemic venodilation lowers the preload, that decreases the left ventricular and diastolic volume, that will decrease the myocardial oxygen demand and reduction of the wall stress. Fall in systemic blood pressure also reduces the wall stress, which leads to further decrease in the myocardial oxygen demand. General management of MI is Babsona. It can also be Mona B. So, but Babsona, okay. It is with the beta blockers, antiplatelet therapy, dual therapy is given, percutaneous coronary intervention, statins, oxygen nitrates, and anticoagulation. So if I say it is Mona B or Mona CB, so M was for morphine, O was for oxygen, N is for nitrates, A was for anticoagulation. Okay. Then we have C is for percutaneous coronary intervention. The B was for beta blockers, and we also give antiplatelet therapy, like we give cilostazol and I guess aspirin. I think it is aspirin. Okay, so these are the drugs which we are supposed to give in the people, but Babsona is also good mnemonic, like we give beta blockers, antiplatelet therapy, dual therapy, percutaneous coronary intervention, statins, oxygen nitrates, and anticoagulation. Management of ST segment elevation by cardiac infarction STEMI. How do we manage that? Firstly, we have to give oxygen for the arterial saturation less than 90%. If it is less than 90%, we have to take it. We have to give oxygen. Nitrates, caution with hypotension, right ventricular infarction, or severe aortic stenosis. Now, If it is right ventricular infarction, you should not give nitrates. If it is severe aortic stenosis, you should not give nitrates because that will lower the cardiac output to devastating levels, right? So avoid that. Just make a good diagnosis before administering nitrates, and they can also cause hypotension, so we have to be cautious about that as well. Antiplatelet therapy include aspirin and P2Y12 receptor blocker. That is one example is cilostazol, and ticagrelor is another example, so we can give any of them. Then anticoagulation, unfractionated heparin, low molecular weight heparin or bivalirudin. Beta blockers, they are contraindicated in overt heart failure, high risk of cardiogenic shock, and bradycardia. Prompt reperfusion with a percutaneous coronary intervention. Ideal first medical contact to percutaneous intervention in less than 90 minutes. That is the time limit is very important. For the PCI, I don't know what do they call it. Like I guess something to the admission to needle time or something, but it must be less than 90 minutes. Like after the initiation of the angina to the percutaneous intervention, it must be done within confines of 90 minutes. Or if the patient was taken to a hospital where the PCA was not available, so the time limit exceeds, like from first medical attention to the percutaneous intervention, it must be less than 120 minutes, because when the person first reaches the hospital, there must be some first aid or there may be some oxygen or anticoagulation must be given at that time, so that increases the time by 30 minutes. So but prompt reperfusion with the PCI is necessary within less than 90 minutes, and statin therapy as soon as possible. Stress-induced cardiomyopathy, which is also called as Takotsubo cardiomyopathy. It is, if you have seen Indian dramas or Pakistani dramas, so there are a lot of women who are, aged women and elderly women of the home, and then when they listen something very emotional, so they just fall down and they are said to have myocardial infarction. That is true because it is most common in the postmenopausal women, and it is associated with some stressful or emotional event. So in Takotsubo cardiomyopathy, this is the octopus trap, and this is what the heart looks like, right? Takotsubo is Japanese for the octopus trap. It is also called as Takotsubo cardiomyopathy or apical ballooning syndrome or broken heart syndrome. It is most common in postmenopausal women. The pathophysiology is acute physical or emotional stress will lead to catecholamine surge that will lead to microvascular spasm, which with consequent ischemia and myocardial stunning that leads to impaired contraction. It is characterized by transient left ventricular dysfunction in the absence of significant coronary artery disease. It is caused by intense physical or emotional stress. The presentation is substernal chest pain, dyspnea, ECG abnormalities, and increased cardiac markers. Now here you can see in the picture that this is a normal functional normal heart. Left ventricular contraction is happening, while in the Takotsubo cardiomyopathy, the upper portions are contracting strongly, while the lower portion contractility is decreased. That makes it look like an octopus trap. So stress-induced cardiomyopathy or Takotsubo cardiomyopathy, the risk factors are post-menopausal women and recent physical or emotional stressor. The clinical features include chest pain mimicking the myocardial infarction, decompensated heart failure, moderate troponin elevation, ECG ischemic changes in the precordial leads. The diagnosis is catheterization, no obstructive coronary artery disease, and on echo you will find left ventricular apical hypokinesis and basilar hyperkinesis. Treatment resolves in several weeks with supportive care. Tachycardia mediated cardiomyopathy. This cardiomyopathy is called as chronic tachycardia. Etiologies include atrial fibrillation, atrial flutter, ventricular tachycardia, incessant atrial junctional tachycardia, and AV-NRT. Chronic tachycardia causes structural changes in the heart, including the left ventricular dilation and myocardial dysfunction, and presents with dyspnea, decreased exercise tolerance, atrial fibrillation with rapid ventricular response, and left ventricular systolic dysfunction. Diagnosis is with ECG and echocardiography. Treatment, aggressive rate control, AV nodal blocking agents, antiarrhythmic drugs, and catheter ablation of arrhythmia. Then comes pulmonary embolism. So we'll read this text and then we'll go to these Google pictures. So the pulmonary embolism presentation is basically pleuritic chest pain. So it is one of the differentials for pleuritic chest pain. Other differentials include post-infarct pericarditis, the Dressler syndrome, and I guess costochondritis can also be considered as a differential for the pleuritic chest pain. And there are others as well which I don't remember right now. But the pulmonary embolism is a differential for the pleuritic chest pain. Dyspnea will be a feature, like there will be tachypnea, the person will be breathing fast. tachycardia, cough, hemoptysis, and lower extremity pain or swelling, that is deep vein thrombosis. Risk increases with prolonged immobilization. The chest X-ray findings have low sensitivity or specificity. On chest X-ray, we can find atelectasis, infiltrates, pleural effusions, West marks sign, which is peripheral hyperlucency due to oligemia. Westmark sign, that is it, this is Westmark sign. So they're saying that it is peripheral hyperlucency due to oligemia. So there are two signs, Westmark sign and Hampton's hump. Both of these things are present on your step exams, rare to find on clinical examination. So Westmark sign is dilation of pulmonary vessels proximal to the embolism along with collapse of distal vessel, often with a sharp cutoff. So the definition was different over there, but okay, this is what they are saying. A Westmark sign. Okay, let me Google that as well. So according to Google, this is Westmark sign, which I can't really appreciate. Okay, this is a picture. Let's see what do they have to explain. So they are saying that the Westmark sign, it results from a combination of dilation of the pulmonary arteries proximal to the embolus. Like suppose embolus is over here, so proximal to the embolus, the pulmonary arteries are dilated. Collapse of the distal vasculature, creating an appearance of a sharp cutoff on chest radiography. Like beyond this point, there is no vasculature, so there is a sharp cutoff as well. Sorry, yeah. Then the Westmark sign has a low sensitivity of 11% and high specificity of 92% for diagnosis of pulmonary embolism. So we can't use it for screening, but once we have screened a patient, once we have a high suspicion, so the Westmark sign can help us diagnose the patient. The other sign is the Hampton's hump. So the Hampton's hump is this one. That's a good picture. So just see that it looks like this, like something like this, Hampton's hump. Okay. Coming back to our discussion, so the Westmark sign, dilation of the pulmonary vessels proximal to the embolism along with the collapse of distal vessels, often with a sharp cutoff, and we can also find a Hampton's hump. This is Westmark sign. Like the proximal vessels are dilated and distal there is a cutoff. But this is a good picture, by the way. I think this is Westmark sign. Hampton's hump is basically a wedge-shaped area located peripherally. That is evident in this picture. Okay. So let's zoom it out. And they were saying that we can find atelectasis, infiltrates, pleural effusion, Westmark sign, peripheral hyperlucency due to oligemia, decreased flow of blood, and Hampton's hump, that is peripheral wedge of lung opacity due to pulmonary infarction. Then we can also find Fleischner sign, that is enlarged pulmonary artery. I heard it for the very first time, Fleischner sign, but okay, this is something enlargement of the pulmonary artery which can also be seen. CT scan diagnosis. CT scan is diagnostic, and I think we do spiral CT angiography, which is the most important test in this thing. But okay, CT scan is diagnostic. The management, check for the probability of pulmonary embolism with the Wells score. Now there is Wells score is a criteria for the pulmonary embolism. If the Wells score is more than 4, pulmonary embolism is likely. If it is less than or equal to 4, it is unlikely. And if it is more than 6, there is high chance of pulmonary embolism. Okay, heparin should be given in the patient with high probability of pulmonary embolism or in whom pulmonary embolism has been confirmed. So modified Wells criteria for the pretest probability of pulmonary embolism. Clinical signs of DVT and alternate diagnosis less likely than pulmonary embolism if we have more than 3 points. More than 1.5 points. Okay. So, okay, listen. If we have a clinical sign, we have clinical signs of DVT and alternate diagnosis is less likely, it has plus 3 points. If we have a previous history of pulmonary embolism or DVT, heart rate more than 100 and recent surgery or immobilization more than 1.5 points, and if the person is presenting with a hemoptysis or cancer, plus 1 point. So the total score is, if it is less than 4 or 4, then it is unlikely, and for more than 4 it is very likely. And if we add them up, 3, 4, 5.5, so how have this made it more than 6? I think it is modified. They were just talking about Wells score, and this is modified stress criteria. So this is Hampton's hump, like the wedge-shaped area over here is the Hampton's hump. Okay. Long distance flights, although a risk factor for venous thromboembolism, do not qualify as immobilization per Wells criteria. So, diagnostic strategy to suspect pulmonary embolism. Firstly, clinical assessment of the pulmonary embolism by modified Wells criteria. If the pulmonary embolism is unlikely, do the D-dimer assay, which is sensitive but not specific. If for the sensitive test, if sensitive test comes out negative, the disease is very unlikely. If the D-dimer assay is less than 500 nanogram per ml, the pulmonary embolism is excluded. If it is more than 500 ml, so we come to this point. Now let's come back. If according to modified Wells criteria, the pulmonary embolism is likely, then we do the CT pulmonary angiography. Right, CT angiography is the gold standard test. And also, if the D-dimer assay in a person with unlikely pulmonary embolism, if the D-dimer assay is more than 500 nanogram per ml, we go for CT pulmonary angiography. If that comes out to be positive, then pulmonary embolism is confirmed. If it is negative, then pulmonary embolism is excluded. Differentials include Dressler syndrome. ECG shows diffuse ST elevation and occurs within 1 to 6 weeks after the MI. Cocaine abuse. So the cocaine abuse, the clinical features of cocaine use include sympathetic hyperactivity, tachycardia, hypertension, and dilated pupils, chest pain due to coronary vasoconstriction, psychomotor agitation, and seizures. The complications include acute myocardial infarction, aortic dissection, and intracranial hemorrhage. Management of chest pain, we do that with benzodiazepine for blood pressure and anxiety, aspirin, nitroglycerin, and calcium channel blockers for pain. The beta blockers are contraindicated. Fibrinolytics are not preferred due to the increased risk of intracranial hemorrhage, and immediate cardiac catheterization with reperfusion when indicated. The presentation is new onset hypertension, epistaxis, tachycardia, and tremor. Suggestive features include early age of onset of hypertension, that is age less than 30 in the absence of family history, severe or malignant hypertension, resistant hypertension despite an appropriate 3-drug treatment regimen, sudden rise in blood pressure in a patient with previously well-controlled hypertension. The diagnosis is urine drug screen. Okay. What are the clues to surreptitious cocaine abuse? Firstly, we'll check for the behavioral features, and if the person is unconscious, we can ask the family or the close friends. Personality and mood changes, changes in sleep patterns, unexplained weight loss, and financial difficulties. Reported symptoms like chest pain, epistaxis, rhinitis, intranasal use, and headache. Examination signs including hypertension, tachycardia, dilated pupils, and psychomotor agitation. Emergent complications, for example, seizures and acute myocardial ischemia, aortic dissection, and intracranial hemorrhage. Illicit drug associated with hypertension. Firstly, the stimulants. So, stimulants include cocaine, amphetamines, MDMA, or ecstasy. This is the name of a drug. Then phencyclidine, that is PCP, and marijuana. The next thing is exertional heat stroke. The differentials include anticholinergic toxicity and serotonin syndrome and malignant hyperthermia. So anticholinergic toxicity, it may also be present with hyperthermia and tachycardia. Anticholinergic like atropine toxicity. So it has a very horrible mnemonic: dry as a bone, hot as a hatter, and something. So dry skin, not profuse sweating, will, like in exertional heat stroke, will have sweating, but in anticholinergic toxicity, the skin will be dry. Non-reactive mydriasis and decreased bowel sounds are present. Multi-organ dysfunction is uncommon. In serotonin syndrome and malignant hyperthermia, muscular rigidity is present. For exertional heat stroke, the risk factors are strenuous activity during hot and humid weather, dehydration, poor acclimatization, lack of physical fitness, obesity, and medications including anticholinergics, antihistamines, phenothiazines, and tricyclics. The clinical manifestations are core temperature more than 40 degrees Celsius, that is 104 degree Fahrenheit, immediately after collapse, and central nervous system dysfunction, altered mental status, confusion, irritability, and seizures. Additional organ or tissue damage, that is renal and hepatic failure, disseminated intravascular coagulation, acute respiratory distress syndrome. Management is with rapid cooling. So we do the ice water immersion is preferred. Can consider high flow cool water dosing, ice wet towel rotation, and evaporative cooling. Fluid resuscitation. Then we do electrolyte correction, management of end organ complications, and no role of antipyretic therapy. Non-exertional or classic heat stroke features. It typically affects the elderly patients in the absence of strenuous activity. Patients have significant underlying comorbidities that limit their ability to escape or cope with excessive heat. Management. Evaporative cooling, for example, spraying lukewarm water while fan blows air on the patient's skin. Okay. Non-exertional heat stroke. It's a classic heat stroke. The previous one was exertional heat stroke. Okay. So in exertional heat stroke, we prefer rapid cooling with ice water immersion. But in the non-exertional heat stroke, we are preferring evaporative cooling. Ice water immersion should not be done as it is associated with increased mortality in non-exertional heat strokes. Then comes the serotonin syndrome. Now, serotonin syndrome is the causes are serotonergic medications. Basically, it is when you have high levels of serotonin circulating in the blood. So there is a constellation of symptoms which we will see in the clinical feature section. So causes are serotonergic medications, especially in the combination, for example, SSRIs, SNRIs. On top of that, you took tricyclic antidepressants or tramadol. Drug interactions like serotonergic medications and monoaminoxidase inhibitor or linezolid. Intentional overdose of serotonergic medications and serotonergic drug abuse, for example, MDMA. The clinical features will be mental status changes like anxiety, agitation, and delirium. Autonomic dysregulation like diaphoresis, hypertension, and tachycardia. Hyperthermia, vomiting, and diarrhea. Neuromuscular hyperactivity will include tremor, myoclonus, and hyperreflexia. Management. Discontinuation of all the serotonergic medications. Supportive care, sedation with benzodiazepines. Serotonin antagonists like cyproheptadine if supportive measures fail. Then we have Wolff-Parkinson-White syndrome. It is a very characteristic syndrome which is associated with a necessary pathway, which is the bundle of Kempf, which can lead to, you know, which can lead to what? Which can lead to that thing, re-entrant pathway. So there are three characteristic features to Wolff-Parkinson-White syndrome. It is W Parkinson-White. So it is W is for wide QRS. PR and the QT interval is that PR interval delta wave. Okay, there was something. I think the QT interval is delayed. The PR interval is less than 120 millisecond, less than 3 boxes, and ST and T wave changes will be there. Presence of initial, okay, this is the delta wave. Okay, just give me a second. Yes, so this is a picture from first aid. I have uploaded the video of this explanation in the step 1 sessions. So here you can see that the Wolff-Parkinson-White syndrome, there is a wide QRS complex. That is WP is for the PR interval shortening less than 0.12 seconds, and the W means there is an additional wave, there is a delta wave. So there will be delta wave, the QRS will be widened, and the PR interval, the P to R interval, this interval will be shortened. Okay, coming back. So the Wolff-Parkinson-White syndrome, this syndrome is characterized by a necessary pathway, that is bundle of Kent, which directly connects the atria to the ventricles bypassing the AV node. So normally, suppose this is the these are the atria and ventricles. So the only connection between the atria and ventricle is this AV node, which is connected to the bundle of His and then to the bundle branches, which give rise to Purkinje fibers and this thing. If there is a necessary pathway over here, that is called as bundle of Kent. I think they have drawn it like that, right? So there is a necessary pathway over here. That is the bundle of Kent. This one. So anterocrate conduction through this pathway leads to pre-excitation of the ventricles, producing following ECG changes. There will be a short PR interval of less than 0.12 seconds. Slurred and broad upstroke of QRS complex, there will be a delta wave. And QRS interval widening, that is sometimes leading to a wide complex tachycardia. QRS will be more than 0.12 seconds with ST or T wave changes. Retrograde conduction from the ventricles to the atria results in re-entrant supraventricular tachycardia. Now here you can see Wolff-Parkinson-White syndrome. Pre-excitation of the ventricles via an abnormal bypass tract. There will be short PR interval. As you can see in this picture, the PR interval has been shortened, less than 120 millisecond, less than 3 small boxes. Yes, that is 2.5 small boxes. So the PR interval is shortened. Then comes the presence of initial slow upstroke of the QRS complex or a delta wave. As you can see, this is a delta wave. Then comes ST and T wave abnormalities. So this is an abnormal ST or T wave that is also evident. So the normal cardiac conduction is looking like this. The SC node produces impulses which depolarizes the atria. First the right atrium, then the left atrium, and then the impulses come to the AV node. They stay there for a while, about 100 milliseconds, 100 to 120 milliseconds, and then they are connected to the bundle face and then to the fibers. Okay, so yes, and then from the AV node to the bundle branches and to the Purkinje fibers. So this is the normal sinus rhythm. In when uh, so then, I'm sorry, you were talking about the accessory pathway, the ventricular pre-excitation impulses like this, and the Wolff-Parkinson-White syndrome. There we have the reentrant circuit. Okay, this is Wolff-Parkinson-White syndrome with the delta waves and the white QRS complexes, and the ST changes, the shortened PR interval, but it is not tachycardia, and the people with Wolff-Parkinson-White are normally asymptomatic. If it becomes if the impulses start getting re-entrant, if there is a re-entrant circuit that has been established, then it becomes re-entrant tachycardia, and then they look something like this. So the complication of Wolff-Parkinson-White syndrome are atrial fibrillation. This atrial fibrillation can bypass the usual rate limiting functions of the AV node, leading to rapid ventricular response. Now, when the atria are fibrillating or even when they are under flutter, the benefit of AV node is that whatever impulse is reaching the AV node, every impulse will not be conducted because there is a refractory period of AV node itself. It only allows some of the pulses to move into the ventricles. So even in atrial fibrillation, the ventricles are protected from the very rapid contractility, or they are protected from tachycardia or fibrillation. But because in this situation with Wolff-Parkinson-White syndrome, we have an accessory pathway, so that AV nodal protection is not there. So in atrial fibrillation, most of the impulses will be transferred down through this accessory pathway, and there will be an increased risk of ventricular fibrillation. Management is with the hemodynamically unstable patients, electrical cardioversion. In hemodynamically stable patients, we do the rhythm control. So if the people are unstable, hemodynamic, we just take a brief history from the people who brought them, and we do cardioversion there and then. If the person is hemodynamically stable, then we start with the rhythm control with anti-arrhythmic drugs such as ibutilide or procainamide. Standard AV blocking agents are not used as they may promote conduction across accessory pathway and lead to degeneration of the AV into degeneration of atrial fibrillation into ventricular fibrillation. If we block the AV node, the only pathway left is now bundle of Kent. Most of the impulses will be traveled from that, will start traveling from atria to the ventricles, and that will precipitate ventricular fibrillation. Now, what is long QT syndrome? The long QT syndrome can be congenital or can be acquired. You can see that the RR interval is this, and the QT interval is prolonged. Okay, so it is characterized by the prolongation of QT interval on ECG. QT prolongation in male, if it is more than 450 milliseconds, it is considered a prolonged QT, and in females more than 470 milliseconds. So more than 2 and 1/4 of the boxes, that is 450. These are 2 and 1/4 of this box. So this is a prolonged QT. It is a marker of torsive depointes and polymorphic ventricular tachycardia. The treatment is with IV magnesium sulfate. What are the causes of acquired long QT syndrome? They can be medications, they can be metabolic disorders, bradyarrhythmias, and others. So for the medications, diuretics due to electrolyte imbalances, antiemetics, for example, ondansetron, antipsychotics like haloperidol, quetiapine, and risperidone, tricyclic antidepressants, selective serotonin reuptake inhibitors, for example, citalopram, antiarrhythmics, for example, amiodarone, sotalol, and plecanide, anti-anginal drugs like ranolazine, anti-infective drugs like macrolides, fluoroquinolones, and antifungals, metabolic disorders including electrolyte imbalance like hypokalemia, hypomagnesemia, and hypocalcemia, hypo everything, starvation and hypothyroidism, the bradyarrhythmias like sinus node dysfunction, AV block, second or third degree. Others include hypothermia, myocardial ischemia infarction, intracranial disease, and HIV infection. So, torsion points. This is twisting of points. It is a form of polymorphic ventricular tachycardia with cyclic or sinusoidal alterations of the QRS axis and or morphology. It occurs in the setting of congenital or acquired long QT syndrome. The arrhythmic episode can present with palpitations, pre-syncope or syncope and may resolve spontaneously or degenerate into ventricular fibrillation and lead to sudden cardiac death. Treatment is hemodynamically unstable patient. We do immediate defibrillation, and in hemodynamically stable patient, we give IV magnesium, effective even if serum magnesium concentration is normal. So we'll keep the session till here, and we'll continue with the multifocal atrial tachycardia in the next session. Until then, Allah Hafiz, be amanillah, and take care.